We have Rosalind Gibson, and Rosalind is an emeritus professor in the Department of Human Nutrition here at the University of Otago. And despite her emeritus status, she remains as busy and productive as ever, and I can vouch for that personally. Rosalind has had a lifelong interest and has made a global impact in international nutrition, working in numerous low and middle income countries. We are very fortunate to have her speak to us today about the use of biomarkers to assess nutritional status, particularly given she is a world-renowned expert in nutritional assessment. So please join me in welcoming Roz.
Thank you very much for that kind introduction. Can everybody hear me? Well, I'm going to give you a slightly different slant because, as Lisa says, my interest has been very much focused on low and middle income countries. So some of my examples will be actually from low or middle income countries. So first of all, I'm going to define and classify nutritional biomarkers and then talk about their application in public health. Then I'm going to discuss some factors that affect the choice of biomarkers and those factors that impact on them with some examples. And finally, I'm going to give you a table of the recommended micronutrient biomarkers that have been developed by the Bond Committee, followed by future solutions. First of all, I'd like to begin by defining what we mean by a nutritional biomarker based on the Bond's definition. This is a biological characteristic that can be objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or responses to nutritional interventions. The value of a nutritional biomarker for public health rests in its ability to accurately assess the nutritional status of populations. Bond has divided and classified biomarkers into these three groups. First of all, the biomarkers of exposure that are generally, but not always, food or nutrient intakes. Then the biomarkers of status, where we measure things in body fluids or tissues. And finally, the biomarkers of function that measure the extent of the functional consequences of a nutrient deficiency. We can subdivide these into two groups: functional biochemical biomarkers, such as enzyme stimulation assays for some of the B vitamins, DNA damage for things like zinc, abnormal metabolites, such as homocysteine for folate, and functional physiological or behavioral biomarkers. These are more directly related to health status or disease, such as vision, growth, immune function, and cognition. Our aim with nutritional status is to try and detect a nutritional deficiency state before we get to the clinical outcome. There are four main applications of biomarkers in public health, and we've heard a lot today about some of these uses, particularly nutrition surveys that were used in New Zealand to assess the overall nutritional status of the population. We also use them in New Zealand for nutrition screening, particularly among the elderly, to identify persons at risk using cutoffs, using simple, rapid biomarkers. We've heard about the need for surveillance, which we hope may happen in New Zealand and Australia, and finally, monitoring and evaluation. We use them to monitor the coverage, compliance, and use of nutrition policies, and to evaluate the efficacy and effectiveness of nutrition intervention programs over time. We have to recognize that population-level biomarkers may not provide certainty about an individual's true status. So what are some of the factors that we have to consider when choosing a biomarker? I've tried to group these under 6 categories. First and foremost, of course, we have to consider our study objectives, including the time frame. Next, the population and setting. Thirdly, the validity and precision, which together measure and assess how well the measurements can be made. Fourthly, the specificity and sensitivity that address and explain how well the results can be interpreted. And we have to recognize that both validity, precision, specificity, and sensitivity are influenced by both biological and external factors. Fifthly, we have to be concerned about the availability of reference limits or cutoffs. These are used, of course, to identify those who are or who are not at risk to adverse health outcomes, which may result as an under or over exposure to nutrients, so that we can hopefully target the group appropriately. And finally, and most importantly, we have to consider the cost and technical expertise. If our study objective is to assess the dietary adequacy, then as we all know and we've learned about this morning, we apply a nutrient intake data. And this figure gives you an example of data from the first national survey on young women of their zinc intakes. And we reported to the Ministry of Health the proportion with usual zinc intakes less than the EAR. And we can see very clearly from this figure that if we'd used the data based only on 1 day 24-hour recall, we'd have provided the Ministry of Health with an overestimate for the prevalence of inadequate intakes. But by adjusting that 1 day to usual intake using the replicates that were used in the national survey, we were able to provide a more accurate estimate for the prevalence of inadequate intakes. Study population is something else we have to consider, and in the national surveys in New Zealand, they grouped their data by life stage group, sex, and ethnicity. And here I give you some examples of various scenarios that have been affected by age, sex, and ethnicity. Pregnancy, as we know, is also a factor that we have to take into account because of a hemodilution during the 2nd and 3rd trimester, but it affects the interpretation of many micronutrient biomarkers. And I have 2 examples here, serum zinc and serum B12. As I mentioned earlier, there are certain biological and external factors that influence the variability of the biomarker, which may confound the measurement and its interpretation. Here, I've divided the biological factors into 3 groups that we have to consider when we're designing our survey or our study. These are participant-related, health-related, and physiological factors, all of which must be considered when we're choosing our biomarkers. In addition, there are certain external factors for certain biomarkers that we also must take into account. Sampling difficulties, including possible sample contamination, which for somebody like myself who's particularly interested in zinc is a huge problem. Hemolysis is another factor because the levels of zinc in red blood cells are much higher than in plasma. Storage is an issue for folate and retinol binding protein and retinol and other micronutrients. And then there are method-related limitations we also have to bear in mind. This slide shows one particularly important biological factor that we must take into account when we're interpreting our biomarkers. And this is the impact of inflammation on 3 micronutrient biomarkers: ferritin, retinol binding protein, and plasma zinc. These data are taken from the thesis of Ali Diana, who was a PhD student from Indonesia in our department. And these are the results of her data of infants at 12 months of age. As we know, ferritin is an acute phase protein that is elevated during inflammation. So it's not surprising that after adjustment, we find a much higher proportion of the population at risk to low serum ferritins than if we hadn't adjusted. In contrast, retinol binding protein and plasma zinc are reduced during inflammation. As a result, after the adjustment for inflammation, what we see, particularly for retinol binding protein, is a large reduction in the prevalence estimate, highlighting the importance of adjusting correctly for inflammation when you're interpreting these biomarkers and giving results to people like the Ministry of Health. Hemostatic control is another factor that we have to consider. The most well-known example, of course, is plasma calcium. Here I have an example of plasma retinol that's used in many countries as a biomarker of vitamin A status. What we see here from this figure is that serum retinol only reflects vitamin A status when our liver stores are either very depleted or very high. This means that in a country like New Zealand, where vitamin A deficiency is probably unlikely, serum retinol is not going to be a very sensitive biomarker of vitamin A status. So we're unlikely to see any correlations between serum retinol and usual vitamin A intakes. Nutrient interactions are another factor that we have to consider, particularly when we're designing interventions based on a single micronutrient. In many low-income countries, multiple micronutrient deficiencies coexist. Here we show the impact of the interaction between iron and iodine. In figure 1, we have the data on the efficacy of an iodine supplement on the goiter incidence of children with and without iron deficiency anemia. And you can see very clearly here that the children who were non-anemic are the ones that responded most to the iodine supplement. Those with iron deficiency anemia, the response to reduction in goiter is much less. This is because iron deficiency reduces the activity of this heme-dependent thyroperoxidase in the thyroid, and this results in impaired thyroid hormone production. In the second figure below, we look at the efficacy of giving iron plus iodine compared to an iodine supplement alone on the incidence of goiter among children, all of whom have iron deficiency. And as we can see, not surprisingly, those children who received the iron plus the iodine have shown a much more significant reduction in goiter than those children given the iodine alone. As I mentioned, there are many biological and external factors that we must consider when we're choosing our biomarker. This is an example in a figure of factors that we know influence plasma zinc concentrations. As we can see from this figure, time of day is an important variable to consider when we're designing our survey, because the plasma zinc concentrations have a marked diurnal variation, being much higher in the morning than the afternoon. The second factor we need to consider is fasting status. Those arrows depict when somebody's had a recent meal, when plasma zinc rises very rapidly and then falls in the next 4 hours. So preferably, it would be good to try and collect fasting samples. If that is not possible, which is the case in many national surveys, then at least we should record the time of the most recent meal. As I've mentioned earlier, inflammation is known to influence plasma zinc and other micronutrient biomarkers. It's important, therefore, to measure 2 biomarkers of inflammation, and the recommended ones now by the Bond Committee are CRP and AGP. And finally, age and sex are known to influence plasma zinc and many other biomarkers, so we need to use the appropriate reference limits. In terms of external factors, as I've mentioned, plasma zinc is affected by contamination, so we have to use these special trace element 3 vacuutamers, and also by hemolysis. There's some external method-related factors that affect assays that we must bear in mind, particularly if we're actually comparing our data across studies. And one of the examples, of course, is with serum folate. If we use the recommended microbiological method, that yields values that are 30% higher than the immunoassay. In terms of serum transferrin receptor, which is used as a biomarker of tissue iron status, we know that the cutoffs that we apply depend on the kit that's been used. So again, we have to be very cautious when we're comparing prevalence estimates of iron deficiency across studies. What about reference limits or cutoff points? There are many factors that influence reference limits or cutoff points, depending on the biomarker, and I've just given some examples here at the top. The second factor that we have to recognize that for some biomarkers, there's a lack of gold standards for the cutoffs. And I've given an example here in the table below of the 3 different cutoffs that are used in the literature for serum B12. The recommended WHO cutoff is less than 148 picomoles per litre, but you can see what a different yield of prevalence estimates you get depending on the cutoff that's used. The third factor that is increasingly being concerned is the choice of functional outcome. And there's a lot of work going on with vitamin D and 25-hydroxyvitamin D, which is the biomarker used. And we found that the cutoffs vary according to the functional outcome of interest. So if you're particularly interested in fracture risk reduction, then you would probably apply a different cutoff than if you were interested in maximum muscle function. One thing that we have to recognize when we're applying reference limits or cutoffs is that there will always be some misclassification that occurs. And this, of course, arises because in a population group, the biomarker concentrations will vary in a normal population because of differences in nutrient requirements in the population. Here we have a figure where the lower curve is the distribution of hemoglobin concentrations in subjects who responded to an iron supplement and therefore were truly anemic. The light shaded area to the right of the 11 grams per deciliter are the anemic persons who would be classified as normal by the cutoff, but in fact were false negatives. So what can we do about this? Well, one way of improving the specificity and sensitivity of our biomarker is to use a combination of biomarkers to examine one nutrient deficiency. Unfortunately, for some biomarkers, we don't have a number of different biomarker indicators to use, but we do for iron. WHO has developed some trigger levels for surveillance and public health decision-making. These are particularly useful to signal public health problems of concern and are used in many low-income countries to try and motivate the Ministry of Health to address these problems of public health concern. So how can we overcome some of these confounding effects? So when we're designing our nutrition survey or our surveillance, we have to go through each of the biomarkers we've chosen in turn and be concerned about how to overcome some of these confounding effects. Well, as was done in the National Nutrition Surveys in New Zealand, they classified the observations by life stage, sex, ethnicity. They recorded medications and supplements and hormonal status, and in some cases, physical activity. They used standardized methods to collect, process, and analyze the data. We also know that if we're using transferrin receptor, we need to avoid using cutoffs that are mismatched for the assay. If we're working in a country like Cambodia, where 36% of the population have a hemoglobin variant, then if we're interested in anemia, we actually need to measure the prevalence of hemoglobin variants, and likewise in a country with malaria. We know now that we should adjust for within-person variation with replicate measures, as we've done in the National Nutrition Surveys in New Zealand for their dietary intake data. We should measure biomarkers of inflammation, CRP and AGP, and apply the new recommended Brinder regression approach to adjust for inflammation. This approach actually takes into account the severity of the inflammation and avoids the use of cutoffs. We know we should try and combine biomarkers instead of using only one to enhance the specificity. And in countries where micronutrient deficiencies coexist and where planning any intervention, we should measure multiple micronutrient biomarkers. This slide shows a new method being investigated for reporting the prevalence of inadequate intakes of iodine in national surveys. Up to the present time, as was done in the national surveys in New Zealand, they measured spot urine samples and calculated the median iodine concentration and compared it with the reference limit. This is a method which is being developed, and what happens here is the first thing is that the iodine spot urine sample is converted to iodine intake based on this equation given here on the right. Here. And this equation was developed by the Institute of Medicine because nearly all the iodine in the last 24 hours is actually excreted in the urine. The dotted line on this graph represents the intakes calculated based on a single spot urine sample. And the unbroken line represents the intakes after they've been adjusted from a subset of repeats, which in this case was more than 10% repeat spot urine samples. And this adjustment has made a huge difference to the prevalence estimates generated. The data here is from these Kuwaiti children aged 4 to 5 years of age. And you can see if we use the unadjusted intakes against the EAR, then 35% of these children were considered to have inadequate intakes of iodine. And after adjustment, this has fallen to 19%. The same trend can be seen with the Chinese data. You can also use this same approach if you're interested in overexposure. I mentioned that it's important to try and improve the specificity of your biomarker by using a combination of biomarkers if available. In the New Zealand National Survey for Children, iron deficiency was defined when at least 2 abnormal values for ferritin, red cell distribution width, and transferrin saturation were used. This again is an example of data from Diana's thesis. And here she has defined iron deficiency and iron deficiency anemia, first of all based on a low serum ferritin adjusted for inflammation. Secondly, on an elevated transferrin receptor, also adjusted appropriately for inflammation. And thirdly, using both low ferritin and elevated transferrin receptor in combination with the algorithm used to calculate body iron. And you can see very clearly that you get very different prevalence estimates for iron deficiency and iron deficiency anemia depending on what biomarker you've used. And this is the one that is actually recommended by using a combination and generates data that's in between the data generated based on a low serum ferritin or an elevated transferrin receptor. Very often it's important to try and use multiple biomarkers of exposure, status, and function. And this slide provides an example of multiple biomarkers that we used in a randomized controlled efficacy trial in northeast Thailand, where we were feeding the children a seasoning powder, fortified or unfortified with 4 micronutrients, zinc, iron, vitamin A, and iodine. This was provided in their school lunch for 31 weeks, and the efficacy of the seasoning powder was evaluated by using an exposure marker, which was the dietary intake, a series of status biomarkers, and also functional biomarkers of growth, morbidity, and cognitive function. And finally, I present the table where I've compiled the recommended biomarkers of exposure, status, and function for 6 micronutrients that have been studied by the Bond Committee. These are available in reviews. I don't have time to go through that in turn, but I do have the references for these Bond. This is the Biomarkers of Nutrition and Development recommendation. And I would urge anybody that is planning a study to read these very useful reviews that provide recommendations of biomarkers, not just at the population level, but also for individuals. So what do we have for the future? Well, there are a lot of new methods being examined out there, some of which I don't really know very much about. I do know that Gates is funding a series of studies that are developing multiplex ELISA assays for assaying multiple biomarkers using very small amounts of blood, which at the moment are under the process of being validated by CDC. The second Gates-funded project, which is also of importance, is the development of field-friendly dried blood spot assays that can be used, particularly in low-income countries, and point-of-care dipstick methods for urinary iodine. It's also important that we recognize that these conversion factors need to be developed when they vary across methods, so that our comparison across methods can be more clear. Metabolomics, as has already been mentioned, is a method which explores metabolites from consumed foods in body fluids as potential novel biomarkers of exposure from foods or dietary patterns. This is being explored, but still requires quite a bit of validation. Nutrigenetics focuses on understanding how genetic variants interact with diet to impact on health, a growing research interest. Gene expression network analysis identifies patterns related to micronutrient deficiencies. And finally, the development of mathematical models to predict, identify, and integrate biomarkers of impaired micronutrient metabolism. So in the future, I can see that some of these approaches will be incorporated in large-scale surveys. So thank you for your attention.